eCQMs and Medicare CQMs are the proposed collection types for APP+. Can you explain the difference between these two options?
Great question, Gloria. You've recognized that in the proposed rule for the Quality Payment Program for 2025, Medicare has proposed to limit the APM performance pathway for accountable care organizations. That's the APM for ACOs, or the APP for ACOs, to the options of eCQMs, that's electronic clinical quality measures, and Medicare CQMs, proposing to eliminate only for MSSP participants the option of submitting MIPS CQMs. If the proposal is finalized, MIPS participants will be able to use MIPS CQMs, just as they always have, eCQMs, or MVPs, MIPS value pathways. There are also a couple groups with some additional options. Small practices of 15 providers or less can use claims-based submissions, and facility-based providers can choose to assign the facility's quality score if it has one. Medicare CQMs will not be an option going forward for MIPS participants. MSSP, that is the Medicare Shared Savings Program participants, will be able to use eCQMs or Medicare CQMs. The web interface finally will sunset after the 2024 performance period and will not be an option in 2025 or afterwards. Now, I think it's a big mistake by Medicare to eliminate MIPS CQMs. I expect they will get plenty of criticism for the proposal. Eliminating MIPS CQMs for MSSPs will push back a lot of progress made in value-based care. I'll explain my rationale on this in a future offering. Now, to explain the difference, all quality measures, whether MIPS CQMs, eCQMs, or Medicare CQMs, even claims-based measures, share a similar structure. Each has specifications that describe the patient visits eligible for the measure. Each has specifications that describe the healthcare interventions that qualify as desirable interventions and qualify the patient visit in the performance in the numerator. The output of the measurement is a ratio of the patient visits that got the desired intervention divided by the number of patients or visits eligible for the measure. The methods differ by the acceptable data sources that can be used, the requirements that defines a vendor that's qualified to help you, and the cohort of patients that can be or that must be considered. I'm going to include MIPS CQMs in my description because I'm voting for their continuation, and I think it's an important method. MIPS CQMs permits any accurate data source, whether it's electronic, whether it's manual chart abstraction, whether it's a paper chart, whether it's an EHR, a local clinical registry data set like a cancer registry or diabetes registry. Any place you can find and deliver appropriate data is eligible for use in a MIPS CQM. Now, vendors that provide MIPS CQMs are called qualified registries. They must be qualified annually by Medicare. There are rules and oversight to which they are subject every year. The quality of their work and their measurements are subject to audit, and registries are subject to censure and ultimately disqualification for departures from the requirements. All patients of all payers of participating practices are included in MIPS CQM denominator specifications. Now, Medicare CQMs are a small but significant departure or subset from MIPS CQMs. The population eligible for denominator inclusions is only Medicare Part B patients or beneficiaries. No other patients of any other insurer are eligible for Medicare CQMs. Otherwise, denominator eligibility specifications are word for word identical to those of MIPS CQMs. Everything else matches MIPS CQMs. Permissible data sources, vendor qualifications. All vendors qualified to provide MIPS CQMs are qualified also to provide Medicare CQMs. Now, eCQMs, electronic clinical quality measures, specifications that eCQMs must use are formatted differently than are MIPS CQMs and Medicare CQMs. The meaning is the same, essentially to the same set of denominator eligibility and numerator eligibility specifications, but it involves acceptable electronic labels for both denominators and numerators. And the data sources are restricted to electronic sources with a direct path to the certified EHR. So the data has to come from the certified EHR. It has to have the clinical nomenclature that's outlined, and vendors that provide eCQMs are not qualified as our qualified registry vendors, but are certified as our EHRs. Now, qualification for MIPS CQMs and Medicare CQMs comes from Medicare. Certification for eCQMs comes from the Office of the National Coordinator, or ONC. Now, eCQMs must be created by a certified vendor from a certified EHR data source. Now, note that, comparing and contrasting the various methods, qualified registries can use, even exclusively, the same electronic data as do eCQMs. That is, that when we, Mingle Health, who is a qualified registry, produce your submission using only the data from your certified EHR, it's the same data set that eCQMs use. If you recall, in the earlier days of MIPS, Medicare offered an all-electronic digital bonus, and we were able to, by choosing to restrict our data to the electronic data set, we were able to get for our clients that digital bonus. Now, eCQMs are by definition digital in nature. They have to use certified EHR data. They have to be certified themselves. Qualified registries can be digital in nature. They can voluntarily or by specification choose to be digital. They can voluntarily restrict themselves to certified EHR data, or they can comply with specifications required restrictions to certified EHR data. Now, they can also use a broader electronic or digital data set than can eCQMs. They can use accurate electronic data that comes from uncertified sources from which eCQMs are restricted. Now, certification requirements are a significant barrier for you as a consumer, as a client. It dramatically increases the expense of quality reporting without improving the accuracy of quality reporting. In fact, certification restrictions can only drive down the accuracy of reporting in a negative way, unfavorable to you, the practice.